Many facilities are switching to the use of Tenecteplase for stroke thrombolysis. In this brief video, I hope to shed some light on the reasons why. Let's discuss a few things today. First of all, I want to discuss the characteristics of Tenecteplase that lead to a favorable clinical profile. By the end of this activity, you should understand the indications and contraindications for the use of Tenecteplase. We shall review the AHA guidelines regarding the use of Tenecteplase. We will review some evidence on the use of Tenecteplase for stroke. Finally, we will put it all together into a recommendation for use in acute stroke in our facilities. Tenecteplase, or Tenecteplase, is a variant of TPA created by recombinant DNA technology. It gets its name from the amino acid substitutions at the T, N, and K sites compared to the naturally occurring TPA. It binds to the fibrin component of a clot and cleaves plasminogen to plasmin. The plasmin degrades fibrin, resulting in recanalization. Compared to TPA, TNK is more specific for fibrin, less susceptible to deactivation by endogenous plasminogen activator inhibitor, and has a longer half-life than TPA of 20 to 25 minutes. Because of the longer half-life, we are able to give a single bolus instead of the bolus and drip required with TPA. It's important to note that TNK costs around $3,000 less per dose than TPA. TNK has FDA approval for the use of STEMI, but is used off-label in stroke and pulmonary embolism. When reconstituted, Tenecteplase is in a 5 mg per milliliter solution. For stroke, we will dose this as 0.25 mg per kilogram up to 25 mg. Tenecteplase contraindications don't differ from alteplase and are essentially anything that can lead to an increased risk of dangerous or deadly bleeding. Relative contraindications should be taken in context of your patient and their deficits. Consider discussing these with your stroke team prior to initiating thrombolytics. Tenecteplase made an appearance in the 2019 American Heart Association Stroke Guidelines when it was noted that it may be reasonable to choose Tenecteplase over IV alteplase in patients without contraindications for IV fibrinolysis who are also eligible to undergo mechanical thrombectomy. This was based on the Extend TNK trial. At this point, there are several post-hoc analyses of the Extend trial, which we will discuss during this video. This study from the New England Journal is one of the many Extend TNK studies. The authors state, intravenous infusion of alteplase is used for thrombolysis before endovascular thrombectomy for ischemic stroke. Tenecteplase, which is more fibrin-specific and has longer activity than alteplase, is given as a bolus and may increase the incidence of vascular reperfusion. Patients with stroke who had occlusion of the internal carotid, basilar, or middle cerebral artery and who are eligible to undergo thrombectomy were randomized to receive alteplase or Tenecteplase. Medicine was provided within 4.5 hours of symptom onset. The primary outcome was reperfusion of greater than 50% of the involved ischemic territory or an absence of retrievable thrombus at the time of the initial angiographic assessment. Non-inferiority of Tenecteplase was tested, followed by superiority. Secondary outcomes included the modified Rankin scale on a scale from 0, which means no neurologic deficit, to 6, which means death, at 90 days. Safety outcomes were death and symptomatic intracerebral hemorrhage. Of 202 patients enrolled, 101 were assigned to receive Tenecteplase and 101 to receive alteplase. The primary outcome occurred in 22% of the patients treated with Tenecteplase versus 10% of those treated with alteplase. Tenecteplase resulted in better 90-day functional outcome than alteplase. Symptomatic intracerebral hemorrhage occurred in 1% of the patients in each group. In this study, Tenecteplase before thrombectomy was associated with a higher incidence of reperfusion and better functional outcomes than alteplase among patients with ischemic stroke treated within 4.5 hours of symptom onset. This is another New England Journal article, which is a commonly cited study from 2012 that was a Phase 2b trial comparing Tenecteplase to alteplase for acute ischemic stroke. This was a relatively low number study. 75 patients were randomized to alteplase or tenecteplase if they had evidence of stroke less than 6 hours from onset of symptoms. Tenecteplase was provided at a 10 mg and 25 mg dose depending on the randomization. To be eligible, the patient had to have a perfusion lesion at least greater than 20% than the infarct core on CT perfusion imaging and a clot noted on CT angiography. The endpoints were the proportion of the perfusion lesion that was reperfused at 24 hours on perfusion-weighted MRI, and the extent of clinical improvement at 24 hours is assessed on the NIH stroke scale, where, as you know, a higher score indicates more disability. The 3 treatment groups each comprised 25 patients. The mean NIHSS score at baseline for all patients was 14.4, and the time to treatment was 2.9 hours. Together, the 2 tenecteplase groups had greater reperfusion and clinical improvement. Tenecteplase was associated with significantly better reperfusion and clinical outcomes in alteplase in this set of patients. The ACT trial was published in Lancet in 2022. The aim of the study was to determine if tenecteplase, given as a single bolus, would increase perfusion compared to the standard TPA bolus and infusion. This is a multi-center, randomized controlled trial involving 22 stroke centers across Canada. Eligible patients were adults with stroke symptoms that would be eligible for thrombolysis presenting within 4.5 hours of onset. Eligible patients were randomly assigned 1-to-1 to either intravenous tenecteplase at 25 mg or their standard alteplase dose. The primary outcome was the proportion of patients who had a modified Rankin scale score of 0-1 at 90 to 120 days after treatment. Safety was assessed in all patients who received any of either thrombolytic agent. 1,577 patients were included in the intention to treat population. 296 of 802 patients in the tenecteplase group and 266 of 765 patients in the alteplase group had a modified Rankin scale score of 0-1 at 90 to 120 days. In the safety analysis, 3.4% of 800 patients in the tenecteplase group and 3.2% of 763 patients in the alteplase group had 24-hour symptomatic intracerebral hemorrhage, and 15.3% and 15.4% respectively died within 90 days of starting treatment. Essentially, this study showed no difference between the 2 medications. The conclusion of this study is that intravenous tenecteplase is a reasonable alternative to alteplase for all patients presenting with acute ischemic stroke who meet standard criteria for thrombolysis. This study from the Journal of Thrombosis and Thrombolysis was published in 2023. It was a systematic review and network meta-analysis to investigate the safety and efficacy of tenecteplase versus alteplase for stroke. This was a meta-analysis. Study authors included RCTs, which evaluated patients with stroke receiving T and K at any dose and utilizing neurologic outcomes as primary endpoint. They also evaluated these studies for safety trends. The analysis ultimately reviewed 9 RCTs, including 3,707 patients. Tenecteplase had higher rates of complete recanalization, but not statistically significant. Moreover, the meta-analysis showed median dose of T and K, which is the 0.25 milligrams per kilogram up to 25 milligrams, had significantly higher early neurologic improvement compared to alteplase. Finally, the higher dose of T and K, which is 0.4 milligrams per kilogram, showed a significantly higher risk of developing parenchymal hematomas. The authors of this paper concluded that T and K in the dose of 0.25 milligrams per kilogram is a promising candidate to replace alteplase as the standard of care in patients with acute ischemic stroke presenting with 4.5 hours of symptom onset, given its higher rate of early neurologic recovery and non-inferiority in terms of safety outcomes. According to the authors of this study, intracranial occlusion site, contrast permeability, and clot burden are thrombus characteristics that influence alteplase-associated reperfusion. In this study, The authors assessed the reperfusion efficacy of Tenecteplase and alteplase in subgroups based on these characteristics in a pooled analysis of the Extend 1A TNK trial. Patients with large vessel occlusion were randomized to treatment with Tenecteplase or alteplase before thrombectomy in hospitals across Australia and New Zealand. The primary outcome, early reperfusion, was defined as the absence of retrievable thrombus or greater than 50% reperfusion on first pass angiogram. Authors compared the effect of Tenecteplase versus alteplase overall and in subgroups based on the following measured with computed tomography angiography: intracranial occlusion site, contrast permeability, and clot burden. Tenecteplase was associated with higher odds of early reperfusion. The difference between thrombolytics was especially noted in occlusions with low clot burden and when compared to high clot burden lesions. They did not observe an association between contrast permeability and Tenecteplase treatment effect. Tenecteplase treatment effect was superior with distal M1 or M2 occlusions, but both thrombolytics had limited efficacy with internal carotid artery occlusions. The authors concluded that Tenecteplase demonstrates superior early reperfusion versus alteplase in lesions with low clot burden. Reperfusion efficacy remains limited in internal carotid artery occlusions and lesions with high clot burden. Further innovation in thrombolytic therapies are required. In conclusion, Tenecteplase is finding favor in the care of stroke. Cost and ease of administration are significant selling points. The literature seems to indicate that Tenecteplase is at least non-inferior to alteplase, and some studies indicate better early outcomes. Remember the rule of 25s for stroke care: 0.25 mg per kilogram, up to 25 milligrams. I hope I've shed a little light on the topic of Tenecteplase for you. Thanks for listening.